Well, good morning. Welcome, everyone. Today I'll introduce you about my PhD topic, about the strategies for the early management of enamel lesions and defects. So I'm Bianca Golzio, and my vision as a PhD student is to translate clinical problems into high-level science. And my mission is to truly bring to clinical practice the possibilities of non-invasive approaches for enamel lesions defects. So in order to achieve this mission, these are my current specific goals, and I'll just further explain them to you. So the first topic is about the efficacy of CPP-ACP on the remineralization of white spot lesions. Well, until the 90s, there's a reduction of 90% in caries experience, especially in high-income countries, due to the widespread use of fluoridated toothpaste. Despite of this, according to Global Burden of Diseases, untreated dental caries is still the most common oral health condition, affecting over 2.3 billion people. Therefore, there's still a need to develop new strategies that can enhance and improve the efficacy of fluoride in reverting and also preventing early carious lesions. So CPP-ACP could be a product for that. It is derived from the milk protein casein, it offers no harm, and some studies show that it can reduce up to 58% of carious lesion area after 4 weeks of use. Therefore, our aim is to evaluate the remineralization efficacy of the combination of CPP-ACP and fluoride versus fluoride alone. So our question is if this combination is in fact more effective than using fluoride alone. And here you can see our PICO frame. And our hypothesis was that this combination is more effective. So the remineralization efficacy was mainly measured with KLF and LF, which are fluorescence-based methods. And our main clinical indication is just to halt carious lesions and its complications, and also to provide the remineralization of those through an easy and safe approach, such as CPP-ACP. Well, this is our systematic search that we have done, and here you can see that we ended up with 15 illegible full texts. So before we come to our results, this is just an overview of the outcomes that we used. So for laser fluorescence, usually gets the fluorescence emitted by the bacterial byproducts, and it converts them into a scale from 0 to 99 according to the carious severity. While KLF uses an extraoral camera connected to a blue light, and through a picture, it quantifies the lesion into a software. And we can see here, the lesion is then identified and quantified into fluorescence loss percentage, and also in the lesion area. So firstly, our results, we have done our results mainly dividing them by follow-up time points of 1, 3, and 6 months. And these are the results for the LF values. So we can see here that we had a high heterogeneity, so there's a lot of difference between these studies. And also, there is no statistical significant difference favoring neither of the groups, and also no clinical significance of these results. For the KLF, now for the fluorescence loss, we can see that at 3 months, we had a statistical significant difference with a pooled MD of 0.58, but now favoring the fluoride group. But still, this was not clinically relevant. For the KLF area, but now in millimeters, so we can see about the lesion area, there is no statistically significant difference between the two groups, so neither of the groups was favored by these measurements. While for the white spot lesion area, so this is the visual change, at 6 months time point, we could see a visual change, so there is a statistically significant difference, but now favoring the group with the CPP-ACP plus fluoride. And there's also, of course, for these three different outcomes, we had a low heterogeneity because there's a low number of studies as well. So in summary, our main strengths is that we used only RCTs. We did our analysis by time points, and also we subgrouped by type of CPP-ACP when it was possible. And we also used the values from change from baseline, which was not used in the previous meta-analysis. So our main limitations were, of course, the short follow-up time and the low number of studies in patients in those studies, and also the high heterogeneity of the studies. So the protocol was very heterogeneous between the studies and also about the patients. So we had a different range of ages as well. So in summary, our conclusion is that this combination of CPP-ACP plus fluoride did not overcome the effect of fluoride alone, and that the progression of early carious lesions could be arrested by the topical fluoride use. So for practice, we could say that this combination has a very little beneficial effect, if any, and that the daily use of fluoridated toothpaste, which was the most used fluoride product, could provide some remineralization of these white spot lesions. So for research, further large sample studies with a longer follow-up time, also following a much more consistent methodology, is needed, besides developing other products than just fluoride that could have a more beneficial effect than CPP-ACP, as we could see in this case. So our manuscript is under revision now after our first round of corrections. It is in Caries Research Journal. And for the second topic, now we will continue with the non-invasive strategies for the management of hypersensitivity and remineralization, but now for MIH teeth. So MIH is a qualitative developmental defect of the enamel that it affects at least one permanent molar, and it varies a lot from severity and from discoloration, as well as we can see in those pictures. So it has a global prevalence of 12.9%, and due to the poor quality of the enamel, it is often associated with several complications that comes from aesthetic concerns, but also hypersensitivity, difficulty in anesthesia, and due to the post-eruptive breakdown, it can even lead to tooth loss. So all in all, these complications could be minimized or even avoided if an early preventive approach would be taken. So therefore, it's really important to understand the evidence base for the non-invasive treatments for MIH complications, since there's still not a definitive clinical protocol established for those. So our aim is to understand which non-invasive strategy is more effective on increasing the mineral content and also reducing the hypersensitivity from these teeth. So our question is if there's a difference in the efficacy of these strategies used. And as you can see, our PICO, we had different interventions that were analyzed, and the outcome was mainly used, but the remineralization was the same one as the previous study, but for sensitivity, pain scales were used. So our hypothesis is that some strategies are in fact more effective than others, and our main clinical implication is to provide better guidance on how to manage the patient's treatment and also how to prevent MIH complications. So this is a systematic search that we have done, and we were left with 14 illegible full text. We have done some preliminary analysis that I'll just show you now. So for the outcome of remineralization, again, we had only here LF, laser fluorescence values, and here we can see the meta-analysis of the means, where we can see the pooled mean of the LF changes from baseline. So the subgroups were done according to the type of product that was used. So we had fluoride varnish, CPP-ACP, and calcium glycerophosphate, and there is no difference between the subgroup means. But we still can see that, for example, the CPP-ACP, we had a pooled mean of minus 1.39 for that case, and there was also a high heterogeneity here, but no difference between the subgroups were seen. And very important to remember also that this is for the mild lesions, so there was a categorization according to the different lesion severity. Now we have the same studies, but now for the moderate lesions. And what we see, again, the same subgroups, no difference between the subgroups, but I'd like to call the attention for the CPP-ACP group, because now we can see that there is a higher pooled mean with a minus 4.87. So we have to remember that this number is referring to the change in the LF, so that's why it's negative. So this is showing how much of the lesion has decreased. So we could say, according to the baseline values, that this would be around a 48% reduction on the lesion size around for these studies. And again, in the end, now we have just the studies who did not categorize according to severity, where we have all the lesions. And we can see here that we had a high heterogeneity as well, and a very wide confidence interval in the group CPP-ACP, and we had the group for the fluoride products. So we have this difference because in one we had the fluoride varnish, and the other one we had the fluoride toothpaste. And we actually had, in this organ B, we had actually an increase in the demineralization. So actually the severity of the caries was even worse after the time. So in summary, our mainly strengths is that mostly RCTs were included, even though that we had some cohort studies. And this is the first quantitative analysis on the available strategies for remineralization and hypersensitivity for MIH. So our main limitations, of course, the widely varying severity of those lesions, and also the broad spectrum of the treatment modalities. So they were very, very different between the studies, and also the low number of studies. And to make further conclusions, we would need more results on the analysis that we still have to perform. As you can see, we have not still some results about the hypersensitivity. So as an overview, my first project was submitted on May 29, and we're still waiting for the response after the revision, and I plan to submit the second one by February 23. So I'd like to thank you for your attention.
Thank you very much, Bianca. How can you treat the MIH, not with these types, but the other ones? Do you know this type? Because this is a new therapy, relative new therapy
yes,
in pediatrician dentists.
Thank you very much for your question. So here we're just addressing mostly the outcomes of hypersensitivity and remineralization, but there are some guidelines established by the European Academy of Pediatric Dentistry, which they mention about the therapies for the intervention themselves. So we have, for example, for anterior regions, and especially for aesthetic concerns, we have ICON, which is a resin infiltrant. But unfortunately, even though that it can reduce the hypersensitivity, but there is not a lot of studies that were addressing this outcome. So that's why, for example, for the hypersensitivity, we have maybe one or two that were addressing, for example, the resin infiltrant and checking the hypersensitivity on those.
Thank you. That was a really nice presentation. I just wanted to ask that there was a, not just by subgroup analysis, but in the second project, I've seen that in many cases, if we collected every data, it achieved some kind of significance. How would you approach this, that if we look every kind of medication, it may be better, but if we just go by subgroup, it does not. Could you make me imagine what's happening?
Thank you very much for your question. So we just have to remember here that we could not perform a pairwise comparison, so we could not have intervention group and then a control group because it was very heterogeneous between the studies, so we could not have a clear control group for all of them. So this is also a problem because all of the studies, they just want, since this is a hot topic in a sense and we still don't have guidelines established, so basically every study did in their own way, chose their own treatments and according to their own practice. So this is also a problem. That's why when we pull them together, we don't have a very clear results from this. And of course, when we are just pulling the means, we have this tendency of thinking that there is a significance, even though that when we see them together, there's not something very clear. So I think this is a matter also of the statistical analysis with the numbers, how we should address this. And this is also, I would say, a limitation from the studies and how can we perform this from them. We tried to do a network meta-analysis at first, but then we didn't have enough connections that were similar. So this is also a problem that we have.